My name is Sandeep Gidvani, and today I'm going to be talking to you about community positions. This talk is part of the Resident and Fellow Education Symposium. For this talk, I have no relevant financial disclosures, but my full disclosures can be found in the NASS program. So these are the objectives of today's talk. Really, I want to define what the different kind of community positions are and introduce to you to the business model of private practice. I want to talk about how to establish an income basis, at the same time highlight what your initial priorities should be once you join practice. I want to focus on long-term goals, develop a personal checklist, and review some of those ancillary income options that can help you when starting out in practice. So most of us are familiar with these different setups, different types of community positions. The solo practitioner tends to be a rare breed these days. A lot of those individuals who are in private practice as a sole standing spine surgeon have gone away only because it's difficult to survive from a financial standpoint. 2 or 3 person practice still exists, sometimes 4 or 5, spine surgeons. And some of the benefits there are you're all doing the same thing, you're of the same mindset, and you find that the conversations tend to be steered in the same direction. There are less sort of quibbles and arguments about how the money is spent and how overhead should be split up. On the other hand, multi-specialty groups are really multi-specialty orthopedic groups with different subspecialties, one of being spine surgery. The other sort of steroid enhanced version of that is a super group. So those large conglomerates of 40 to 90 surgeons in the same group. Sort of as you increase in number with respect to the group size, what you're really getting is an increased ability of contracting power. So working with insurance payers to improve your reimbursements for both clinical visits and surgeries. The other sort of versions of employment include hospital-based employee or healthcare organization employee. There, you're truly an employee where you're paid a salary, and so that monthly sort of concern about how much income you generated is not there. But at the same time, it tends to be a little bit more restrictive in terms of your personal schedule and flexibility. So this is the business model that most private practices will employ. So it's important to understand the components of each of these main headers, income generators versus costs, as essentially the balance of these is what leads to your profit for the practice. So we're all familiar with the practice of spine surgery, seeing patients in clinic and then performing the surgery. And each of those will generate revenue. For those patients who you treat non-operatively for certain issues that you may be using braces, in particular for deformity, for those patients who you do surgery on, there are some that will get a post-operative brace. So having a system in which you keep those braces in-house and being able to bill for them is important. Bone stimulators, variable in terms of how consistently you can get reimbursed for these, but if you develop a good model, again, for bringing them in-house and accounting for them, you may be able to generate income. In-office procedures tend to be more rare for spine surgeons, but if you have a physiatrist in office who's doing injections and you're referring the injection patients over to them, that might give you some component of income generation. Clinical studies are another good way that a practice can generate revenue, as there's a setup process and workflow, and once you've got consistency there, again, you can generate income. And then something that tends to be a bit more rare but can be quite profitable is an in-house pharmacy. So dispensing medications requires a person to be responsible for the accounting of medications coming in and being dispensed, and then certainly being able to generate revenue from that is an additional key. Costs. So if you own the building, not so much, but if you are renting or paying a monthly lease, then you have to incorporate that. Medical staff, so everyone from your casting technicians to your schedulers to your medical assistants to your billers are part of your medical staff. And in addition to paying their salary, you also have to account for their health benefits. You have to think about your EMR, and sometimes billing is incorporated within that, so that might save you some of the costs, but those are certainly costs that you have to bear. Supplies, so if you have a multi-specialty orthopedic group, casting, splinting supplies, technology and equipment. So the desktop or laptop that you use to utilize the EMR, in addition to maybe a flat screen TV that you have in patient rooms in order to show them their imaging. Equipment like X-ray equipment or an MRI scanner, and then certainly accounting for the upkeep, licensing for those equipments, and when they break down, the cost that is incurred as well. So now that you have that model in your head, you think about, okay, well, how am I going to generate income within that first year? And the first year is different from every year after, mostly because there's a burden in place, and the burden is you, and you have to think about who's going to initially support that burden. If a hospital is guaranteeing your income, then from the practice standpoint, the burden tends to be neutral, meaning it's not falling directly on you and it's not necessarily falling on the practice. In some ways, however, it is still falling on you, and the reason being that there's usually a clause within the income guarantee contract that demonstrates how you will make up for that cost, or make up for that salary. So in some cases, you may have to take call at the hospital, and they know that because you're taking call, you have to treat the patients there because that's where they're being admitted, or there may be other variations of that. In some cases, the practice themselves will take on the burden of your salary or fixed cost for the first year. That is very admirable, because remember, those partners are essentially shelling out individual contributions to be able to support you. At the same time, that's a great model because it makes the individual partners invested in you, because they know that you have to succeed for them to succeed and for them to get their money back. So it's a sort of mutual benefit strategy. And then for those who may be a bit more experienced or willing to take on a bit more risk, you may be employed under a commission model where there's a fixed percentage overhead, and that burden really falls on you. And maybe it's not even so much a burden because it depends upon how much you wish to take home. And depending on how hard you work, ratio-wise, you'll get paid a certain amount. There's different variations of the percentage overhead that you may be presented with. If they say we'll do a 50-50 split, really they're trying to help you. They're saying, okay, whatever you bring in, we'll assume 50% of that is due to us providing you with a scheduler, assistant, a biller, and a place to see patients. And 50% is yours because you're doing the work, and certainly you're doing the surgeries. You can certainly vary that percentage as well. So they may say to you, okay, after 6 months, let's increase that overhead to 60%. And the reason why is they want to emulate what it's like to be in the situation of a partner. And then you can sort of feel the burden of partnership, which would be accounting for the overhead to run the practice. And that might be a way to test what it's like to be a partner without the financial obligations that come with being a partner as well. So those are the different kind of models that exist for income basis in the first year. And really the key is what happens after year one. It's interesting that when you first look at a contract or you're looking at a position, really a lot of the focus is on year one, but you'll have to also have a long-term mindset. In the first year and in every year after that, what's going to help you succeed are the 3 A's: affability, ability, and availability. But at the same time, how can you help yourself? So there are different things you can do as part of your practice to continue to generate income beyond what you will maintain with clinic visits and surgery. So call stipends, and those can be sizable depending on where you take the call and the level of trauma that comes through that hospital. And this can be general orthopedic call, or it can be spine call. Typically in California, the spine call is handled by neurosurgeons in the community, which makes it difficult to get onto those call panels. But you certainly can talk to administration and see if that's something that you could do. It does help build your spine reputation and your presence within the community if you can do that. As I mentioned, you can take general orthopedic call, and you can also do general orthopedic cases. So although we're all fellowship trained prior to going into spine surgery practice for the most part, you did do a 5-year residency where you should be pretty familiar with general orthopedic cases, in particular traumatic injuries like ankle fractures, tibia fractures, hip fractures. Those are relatively straightforward to manage. Oftentimes there's a hospitalist involved, so the burden on you beyond the surgery is relatively small, but at the same time you can generate income. You can obtain assist fees. So in particular for the senior partners in your practice who perform spine surgery, you can assist them. You don't have to take on the burden of seeing the patient and walking them through the postoperative course, but at the same time you get exposure to different types of spine surgery. So if you have a partner that's MIS focused or deformity focused, that gives you exposure. It may enhance the services that you provide. It puts you in contact with the representatives from different implant companies. So overall, though you're not making the same amount of income you would make if that was primarily your case, you're still getting a great exposure, and it helps build your practice. Consulting can exist in various forms, in particular with implant companies is one of the most common versions. So you can engage in that if you wish to. In terms of how you succeed there, oftentimes you'll hear crawl, walk, and then run as far as your engagement with the company. And so it does take some time to generate a decent amount of consulting revenue if that's your goal. Same goes for medical legal opportunities. For example, in California, you can be a qualified medical evaluator, really provide a third-party perspective to insurance companies that are dealing with workers' compensation claims and help guide the treatment of patients. It does require report generation. It does require time on your end, but it can add to your weekly or monthly income generation. There are also non-income generating activities you can participate in. So certainly talking to the community, giving different kinds of spine surgery topics to the community, and showing really what your skills are is a great way to bolster your practice within your group. It gives you exposure to patients. It gives you exposure to other physicians who will come and attend your talks as well. And it may or may not lead to patients coming into your office. So it may be a passive way to build income, more so from an exposure standpoint. You can also do something called meet and greet. So this is not as common in today's world, but when I first started in practice, I did this quite often, essentially set up an appointment to go into the referring providers' offices, whether they're internists, physiatrists, neurologists, and let them see you face-to-face and kind of chat with them both about practice and on a personal level. It helps you build connections. Obviously, in the COVID pandemic era, this has gone away. And in place of that, what we've continued to do are Zoom meetings where at least you can engage face-to-face, and so they can see who you are. They can sort of get to know you and know that they can call on you when there's a need, especially for spine surgery or spine services. And this can be for non-operative management as well. One thing I'd like to mention about that is, if you're in a practice where you have an MRI scanner, it may just be that they refer you over patients for your ancillary services like MRI or physical therapy. But again, it's helping you generate income and build your business. It's important to stratify your priorities. So in that first 2 years of practice, you have to think about, what's the main goal for you? Certainly, you want to build volume and demonstrate to your partners that you're proficient in your practice of spine surgery. But at the same time, you're balancing that need with the need to collect cases for your boards. In that process, you're going to have essentially pretty stringent indications for why you do surgery, or you at least should be able to justify or give rationale for why you decided to do surgery. And sometimes that will limit your growth because you become a little bit of a head case about it. So it's important to ensure that you're still challenging yourself when you're in the board collection period, but recognize that you're going to be a little slow to start. And so build that into the conversation when you look at these community positions, and make sure that they sort of understand that coming in, and that, they're not, they have a reasonable expectation of you. At the same time, you want to really do self-reflection along the way. So take time to assess that practice. Not only your practice, sort of, your day-to-day, but also how is the practice doing? How are they incorporating you? What are they doing to help you grow? And at the same time, where are they heading as far as a direction? And make sure that that's something that is in line with your priorities. And so now we move on to long-term goals. So hopefully within that first year, you've been able to work through the hurdles of establishing yourself, and now you're at a steady income state. And once you're there, the next step is then to look at the partnership model. And you should have been doing that all along, but now you're starting to take a critical look at it to see if you can make the jump. In doing so, you should look at, in that first year, what was your case mix? What kind of cases were you able to do? Was it in line with what you were anticipating when you first joined the practice? And at the same time, what is your case load? Is it comfortable, or can it be increased? And if it is increased, is that going to be something that is within the realm of spine surgery that you want to practice? So is it going to be all deformity now, or can you continue with the degenerative practice if that's what you had in mind? You want to think about continuing to drive revenue. And so one of the ways that spine surgeons will do that is to hire a physician assistant. But you have to realize that the practice typically is not going to totally bear that cost. They may bear some of it, but a majority of that cost is going to come from you. So you have to make sure that you're efficient in your clinic and in your surgical practice to be able to incorporate another individual. You have to be able to delegate responsibilities. Certainly, as you do, they will also be billing and generating income to offset their own cost. But you have to think about these strategies and how you want to utilize a physician assistant to grow your practice. Oftentimes, in an experienced or mature practice, a physician assistant is really seeing non-operative patients or screening patients, and then the physician or surgeon is really focusing on those surgical patients and those conversations. And again, don't forget about personal satisfaction. So if you're happy with what you do on a daily basis, it's going to make you happy to go to work, and that's how you continue to grow. If you're not, that's going to be a problem. And so when you look at these positions, I've developed a personal checklist. You should make your own, but these are some of the main pointers that I've used in ensuring that the position I'm looking at was right for me. So certainly location is paramount, right? So you got to decide where you want to be, whether it's close to family or friends. Do you have a network there? So that comes first. And once you've decided on the location, then really you ought to look at all the opportunities that are there. If you find one and say, wow, this is golden, this is amazing, don't hesitate to look at the competitor and just to kind of get perspective. Really think about your partners. So personality is important. Engagement is important. Are they interested in talking to you? Do they appreciate you being there? Can you talk about things outside of work as well? Really that helps you determine if that's going to be a long-term fit. Think about their reputation. So you might say, well, how do I assess that? Because I'm talking to them directly. Well, when you go on those interviews and talk to the other partners in the group, sort of get a feel for how they interact. When you go to do an interview or take a look at the operating rooms or hospitals that they use, don't hesitate to talk to the personnel about the reputation of the practice. Of course, if the hospital and the practice are really trying to bring you in, you might get a skewed view of this, but it doesn't hurt. You get certain insight into how those partners run their practice and what the reputation is within the community and the hospital. Also talk to referring providers, or if you have any family or friends in the area, sort of get an idea for which doctors they go to, and that might be another a key in. Talk to the partners of the same subspecialty. So, in your interviews, typically you're going to interview at least with another spine surgeon. If there are multiple spine surgeons in the practice, think about whether or not you have the opportunity to talk to them. If not during the interview, then outside of the interview. If one or two of them are really shying away from a discussion with you, then you might want to consider if there's a reason for that. Perhaps they're not totally on board. Perhaps there's not enough volume for you to come on board and be successful. So try to investigate that without being off-putting. We've talked about this. Really look at what kind of spine practice you want to have and ensure that you have the ability to do those kind of cases. Look at the practice's hospital alliances. So this is important for a number of reasons. In particular, if you want growth and you have a hospital alliance that can work with you, that's going to be very useful. Oftentimes, the hospital will pay for or help put on marketing events, community lectures. In addition, if they're invested in your growth, they will give you block time or make block time available. And then there are other types of things you can do where you can do co-management agreements or work together with the hospital personnel to ensure that there's efficiency in your workflow and how patients are treated within the hospital after surgery. And finally, what is your individual schedule or responsibility? What's your weekly schedule? And who do you have at your side? Are you going to get a medical assistant or physician assistant? Who's your scheduler? How many people did they schedule for? Are they going to have time for you? Who's your biller? Are they somebody who's familiar with spine billing, or have they mostly done shoulder surgery and now this is totally new for them? And how long will it take them to get up to speed? As these will all factor into your again, your revenue generation and your growth of the practice. And finally, we've talked about some of these components already, but ancillary. So one thing we haven't discussed is surgery centers. So in our situation, in a multi-specialty orthopedic group, we're really allowed to choose which surgery center we want to affiliate with. I think those practices that have the greatest success are the ones that build their own surgery center, and that takes time, investment, and some degree of mentoring from an outside group. But this is really where you can succeed and make the most use of your day. You can be efficient, and patients really love it. If you are going to join a surgery center, think about what your buy-in is, and at the same time, what's the expectation? How many cases are you expected to bring there? Typically, they say 1/3 of your volume, but what's the reality of that? And what kind of cases are they expecting you to do there? Because that has a lot to do with your comfort, in terms of more complex cases. Are you going to be able to be comfortable doing those in surgery centers, or do you need a hospital environment? In our practice, we have MRI and physical therapy on site. Certainly, this is useful to the patients and helps generate ancillary income to offset your overhead. Same goes for DME or durable medical equipment. Talked about call stipends, consulting, and med legal work. One other additional means of ancillary income generation is workers' compensation clinics. So these are patients that are sitting in an outside clinic. They've gone through a screening process, as they've more than likely already seen a primary treating physician who works them up, and then they've seen a physiatrist who has maybe walked them through injections. They've gone to physical therapy, and now they really are in need of spine surgery services. And so these can be high volume or high yield clinics. They can help contribute to filling your OR block time, and of course they generate some degree of revenue. Oftentimes the offset is that you have a significant paperwork burden or load, but if you can find ways to be efficient and use templates, this may be worth your while. We mentioned clinical studies in terms of revenue generation or ancillary generation, and finally bundled care programs. So there are third-party companies that you can work with that can help you with managing episodes of treatment, in particular with Medicare patients. As far as spine surgery, this sort of was in favor and now is going out of favor, but I think it will come back in a different format. So just pay attention to these. So in summary, there are different types of community setups, and you really have to pick the model that's right for you. All the while, keep in mind the business model that we talked about, and don't hesitate to return to that slide. Think about how you'll continue to generate income and how you can continue to build in the left column, to offset the costs. You always want to differentiate between your short and long-term goals and keep those in mind when you're looking at positions. Develop your own personal checklist, and don't forget about ancillaries, because especially in year one, you may need those. And once you've established them, they're going to be in place for the long run. Thank you.